And you mentioned the scaffolds and that sort of thing. So this is people might know this in terms of terms like microfracture or autochondrocyte replacement, or Macy's technique, which is a membrane autochondrocyte implantation. Generally speaking, am I right again? And they're more suited towards isolated, cartilage lesions where there's just one little osteochondral defect, as opposed to the whole knee being diseased, or there's multiple sites where this.
Yeah. I mean, the best analogy I can use is that if you think about the knee surface as akin to a road. So if that road is, you've got freshly tarmac road, and there's one pothole, we see it in the snow and ice and that sort of thing, and there's one sort of pothole, those are the ones that respond well to some kind of either drilling that area or putting some kind of scaffold, some kind of filler into that zone, because you've got an edge to it that will allow it to stay in, Where your road is more sort of crater shape, more kind of gravel, there's no one area that you can sort of, you can try and patch up one area, but the other area is just as bad. So you then, in those sort of situations, just going down the biologic route or the replacement route, depending on how, severe the symptoms are, would be the better option. So the scaffolds, sorry, go on.
Yeah, so the other thing that people might sometimes have, they might experience, is they might have, because a knee, like you say, like a road, it's actually like a road on a road, isn't it? So you might have a pothole on this side, but then a matching pothole on the other side. That's what we call a kissing lesion. And again, that's not an ideal combination if they've got that, because I think, is that right in saying? Because again, it's going to be harder then to stimulate and flatten off those two.
Yeah, if you scaffold both sides, then it's probably going to fail. So I think when you've got those kissing lesions, then you've got to look at different options. But we try and do. I guess our philosophy is always trying to do the least possible, in terms of least possible to get the best results. To try to enhance the patient's own bone, whether it's stimulating that with what we call a subchondroplasty, where you put calcium phosphate into that sort of stressed area of bone, and then doing some kind of cartilage work, as opposed to just jumping in to replace. But again, it depends on that patient.
An end game point, really, isn't it? So. Yeah, fantastic.